Good afternoon to everyone, at least afternoon for those who are in Europe, and welcome for all of the others who are outside of Europe. And today's webinar is about to start. I'm going to be the moderator. My name is Attila Jakob, and it's a pleasure to be a moderator of this seminar. I obstetrician and gynecology at the University of Debrecen, which is located in Hungary, in eastern part. And my specialty is the reproductive endocrinology, ultrasound diagnosis in OBGYN, and the gynecological endocrinology. Today, we are going to talk about the risk factors for endometrial cancer. And if you have any questions, we are going to have two lectures by Professor Tevfik Yoldemir and Professor Ludwig Kiesel. And after the lectures, we are going to discuss your questions or our questions, our comments. If you have any questions in between the talks, then please use the question and answer button and just write the questions, and we are going to see it. So the first lecture is going to be delivered by Professor Tevfik Yoldemir about the endocrine and genetic factors of the endometrial cancer. Professor Yoldemir he's a full-time professor at the Medical School and the Health Sciences Institute of Marmara University in Istanbul. And his fields of interest and expertise are reproductive medicine and surgery, menopause and menstrual disorders, medical and surgical management of the endometriosis, and minimally invasive gynecologic surgery, both laparoscopic and hysteroscopic. He is the member of the IMS, EMAS, ESG, ESGE, and the International Academy of the Human Reproduction, as well as, in addition, he is a board member of the European Society of Gynecology, ESG, who is presenting this seminar, and co-chair of the Council of the Affiliated Menopause Societies at IMS. So thank you for Professor Yoldemir. This is a privilege to have you, and I ask you to deliver your talk. The screen is yours.
Thank you so much for the introduction, and also for the invitation. Well, today I would like to discuss with you the endocrine and the genetic risk factors related with endometrial cancer. Well, one of the studies from UK Biobank data revealed that the circulating concentrations of total testosterone was related with increased risk of endometrial cancer. And that was the same for free testosterone serum levels. And an inverse association was found in that study with the sex hormone binding globulin. And when they checked insulin growth factor 1 levels, they found no association with the endometrial cancer. Mendelian randomization is used mainly to study the causal relationship between exposure and disease. And in this study, with the Biobank data in UK, they looked at the observational and the Mendelian randomization estimates, and they were similar. So with the total and free testosterone levels, there was a significant increased risk for endometrial cancer. And for the sex hormone binding globulin, the association was reversed, and there was no relationship for insulin-like growth factor. They did subgroup analysis of their data, And when they stratified the data in terms of menopausal status, age at menarche, number of parity, follow-up time, and age at the diagnosis of the cancer, the total testosterone was positively related with endometrial cancer. The relationship was reversed for sex hormone binding globulin. However, in cases of premenopausal women, those women having a menarche after the age of 13, and those who had more parity than 2 children had no difference in terms of the risk of endometrial cancer. Another study compiled different works which also use Mendelian randomization in terms of some serum parameters. And here, testosterone levels, bioavailable testosterone, cortisol, and estradiol levels were found to be increased in endometrial cancer patients and also in those who had endometrioid type of endometrial cancer. The only increased risk for bioavailable testosterone was found for the non-endometrioid type. When they checked the blood lipids, HDL cholesterol was high for endometrial cancer and endometrioid type cases, whereas the LDL cholesterol was found to be inversely related only in non-endometrioid endometrial cancer. And sex hormone globulin, as it was seen in the previous study, was inversely related with endometrial cancer. Fasting insulin was increased both in all of the endometrial cancer cases and also in endometrioid type of patients. Here in this review, neither type 1 nor type 2 diabetes had increased risk for endometrial cancer, and the use of metformin had no association. Another study looked at other parameters, for instance, glycolated hemoglobin levels, triglycerides, apolipoprotein B and apolipoprotein A1 levels, and they used the Mendelian randomization. In this study, as you would see, only type 2 diabetes was shown to be barely related with increased risk for endometrial cancer, and only in those having endometrioid adenocarcinomas. The fasting insulin was increased for the overall endometrium cancer cases and only in endometrioid type cancer. Glycosylated hemoglobin was found to be a risk factor only for non-endometrioid adenocarcinoma cases. And lipoprotein B was found to be inversely associated only in non-endometrioid adenocarcinoma cases. A study which reviewed 21 articles had looked at different serum parameters, and they found that the testosterone, type 2 diabetes, plasma cortisol, and free testosterone levels were increased in endometrial cancer patients, whereas the sex hormone binding globulin was found to be having an inverse association with the cancer type. Here, endogenous 17-beta estradiol was found to be associated with increased risk of endometrial cancer and also in endometrioid type conditions. Well, a study which compiled 16 different articles, including almost 30 300,000 participants found that sex hormone binding globulin levels had an inverse relationship with endometrial cancer. Testosterone levels were highly related, and the same was true for free testosterone and androstenedione levels. However, there was no association with the dihydroepiandrosterone levels, while the dihydroepiandrosterone sulfate was barely linked with increased risk of endometrial cancer. When they checked the estradiol estrone levels in the serum, they were related with increased endometrial cancer. And the same was true for the unconjugated estrone and estradiol. However, there was no association between the cancer risk and the levels of conjugated estrone and conjugated estradiol levels. In this study, they also checked for the estriol levels. The estriol and the unconjugated estriol levels were linked with increased risk, while the conjugated estradiol had no relationship with endometrial cancer. So, metabolic dysfunction is a cause for the endometrial cancer, and it might trigger inflammatory cytokine release or might cause altered hepatic signaling, hormonal imbalances, and the activation of intracellular pathways through which mitogenesis, angiogenesis, and cellular proliferation might result. And in this scenario, fatty acids and cholesterol metabolism might play a role where the energy is derived for tumor cell survival and growth. And the pathways in this metabolism would control the cancer cell viability and growth, and the tumoral proliferation and invasiveness and migration to other areas might be related to the energy that is derived through fatty acids and cholesterol metabolism. And here we see that the cholesterol biosynthesis might result into tumor growth and metastasis regulation. And this growth is due to the dysregulations in the normal cholesterol biosynthesis, and we will see them in some of the slides that I will show you in a while. Fatty acid oxidation is another pathway where tumor proliferation and malignant characteristics might drive in dysregulated cellular mechanisms. And as you would imagine, it's all dependent in a way on the diet a person would consume. So the consumption of high calorie foods or staying away from those high calorie diet is the key point for lipogenesis, lipolysis balance. And together with the hormonal dysregulations of either estrogen, progesterone, or androgens, the metabolic instability together with lipids, metabolism disorders, and glycolysis, these might lead to, of course, together with genetic problems, might lead to the cellular damage and, of course, DNA damage, which could eventually lead to the generation of cancer. Here, androgen receptors and the androgen metabolism thereafter plays also a crucial role in terms of the growth factor receptor changes and signal transduction together with the secondary messengers which would lead to endometrial cancer. There are many molecular mechanisms involved in the occurrence and also on the progress of endometrial cancer. One of them is gene mutation. So here we see a couple of genes and how they are present in the different types of endometrial cancers. So different type of mutations would be present in type 1 or type 2 cancers. For instance, the mutations of TP53 would be highly frequently seen in type 2 cancers, while the PTEN mutations and KRAS mutations would be more seen in the type 1 carcinomas. So these different gene mutations might result in endometrial cancers. Then we have the DNA mismatch repair genes. And these, even though there could be sporadic modifications without any inheritance through genetic predisposition, these modifications through somatic mutations or epigenetic modifications might lead to dysfunctions of the mismatch repair genes and eventually might lead to endometrial cancer. And we know that the different genes would have increased risk of endometrial cancer, as you would see in these tables, when compared with the general population. For instance, like 35 to 54% endometrial cancer risk for MLH1 Lynch syndrome. So there are some hereditary genetic mutations present there. Another cause would be hormonal signaling imbalances in estrogen and progesterone receptors and the mechanisms thereafter. Estrogen is known for its effects on cellular proliferation, angiogenesis stimulation, and apoptosis inhibition. So any high expression of the alpha receptor or the loss of the expression of the beta estrogen receptor might contribute to the development of endometrial cancer. And it's not only at the receptor foci, but also the metabolism of estrogen do have influence on endometrial cancer. The estradiol, estrone sulfate are found to be higher in endometrial cancer patients, as I had shown in some of the earlier slides. And the sulfatase and sulfotransferase are aberrantly expressed in endometrial cancer patients. So it's not only at the receptor position, but also the metabolism might be affected. Progesterone would decrease the genes involved in the progression of cellular cycle through either cyclins or cyclin-dependent kinases. And it is considered as having a protective factor in terms of its anti-proliferative effects on the endometrial cancer cells. And it regulates through the TGF-beta pathway, which would have a kind of preventive role in terms of cancer cell viability. Another cause would be the epigenetic modifications, and these involve DNA methylation, histone modification, microRNA dysregulations, either through hypermethylation of the promoter regions of a tumor suppressor gene or hypomethylation of an oncogene, they would promote tumorigenesis. And also through the acetylation and deacetylation of the histones, again, tumor progression and metastasis would result. So the biogenesis of microRNA might be dysregulated, and at the end, what we have, the end result, the target messenger RNAs would have change in their gene expression, and these might have an effect on the progression of endometrial cancer. It has been shown that some microRNAs are increased and some are downregulated in endometrial cancer cases. And some of the microRNAs, they act on they are increased through the effect of estrogen, while some of them would be affected by the progesterone. And their imbalance would actually would affect the balance between the estrogen and progesterone on the endometrium, and through different cell pathways, which I will discuss in my talk, will lead to endometrial cancer. Another cause would be through the activation of angiogenesis. And the activation of PI3K ACT-mTOR pathway is where the endothelial cells would proliferate and would kind of, in tumoral processes, would kind of provide the survival of the cells. And the epigenetic alterations, as I've discussed earlier, through DNA methylation, histone modification, might also cause angiogenesis and formation of abnormal blood vessels. MicroRNA also would modulate apoptosis and will cause blood vessel formations. And their modified expression also would be a functional effect on the vascular, increased vascular permeability, and also on the angiogenic signaling, increasing angiogenesis. Polymorphism has been linked with increased endometrial cancer risks, and they have been found to influence either hormonal regulation or influence the DNA repair, or act as pro-oncogens, or would have an effect on cell cycle regulations, and even interfere with the homeostasis genes, which would block the enzymes that would cause blood clotting. And the polymorphisms are not, they can be obtained not in a genetic, in a hereditary way, but they can be also taken through mutational and epigenetic events. So let's say that a patient would have a cancer driver gene in their normal endometrial epithelium, and they would be dormant. And the cancer driver genes that are rarely found in normal endometrium would just be appearing in the cancer cells. So a single endometrial gland might have the driver mutation, but this would be having this would have a limited capacity. So malignant transformation would not occur unless an additional mutation or an epigenetic event occurs and would increase the capacity for further carcinogenesis. So we know that these polymorphisms, some are rarely seen, and these have high risks, and most of them are less common, and they would have they would be more common, but thankfully will have low risks for endometrial cancer. And you would see here some of the genes having lifetime risks more than 20%. Well, I mentioned that some signaling pathways are responsible for the progression of endometrial cancer, and they are in play through either the modifications at the genetic level or epigenetic regulations that would increase the cellular mechanisms toward cancer development and progress. One of the pathways is phosphorinoside 3 kinase, mTOR AKT pathway. Here, some genetic mutations and epigenetic dysregulations like hypermethylations would cause this pathway to move in the way of cell proliferation, angiogenesis, tumor genesis, and in the instability. Another pathway would be the Notch signaling pathway. And again, some mutations at the gene level and some epigenetic modifications would cause this pathway to move in a cancerous direction. Another pathway would be the RTK-RAS MEK-RAF signaling pathway. Here again, mutations and epigenetic alterations would cause cell growth, angiogenesis, and invasion of the cancer. Wnt signaling pathways is another pathway which is seen for the progression of cancer, and the same is true for TGF-beta signaling pathway, which would end up in biological events in favor of cancer. Hippo signaling pathway would also cause cell proliferation, increase cell proliferation, and tumorigenesis. And the receptors on the cells, either through receptor tyrokinase or the Wnt or VEGFR receptors, each would eventually, if they have genetic modifications at certain steps or epigenetic alterations, would lead to proliferation, increased proliferation, decreased apoptosis, increased angiogenesis, and of course, these will lead to cancer development and progression. We have endometrioid type endometrial cancers and non-endometrioid type cancers. And here, as you would see, that different signaling pathways are taking role in each different cancer types. And they behave also differently, like the endometrioid type is generally more favorable, has a more favorable prognosis than the non-endometrioid endometrial cancer. So we know that genetic mutations, epigenetic alterations are a cause of endometrial cancer, and the same is true for unhealthy lifestyle, our diet, and the metabolic syndrome a patient might have. And through either hyperglycemia, hyperinsulinemia, dyslipidemia, and the irregularities in lipid uptake, biosynthesis, and metabolism, through different pathways, there is increased cellular growth, decreased apoptosis, and the risk of endometrial cancer is increased. So insulin through hyperinsulinemia might affect through different pathways. And one of the pathways is PI3K mTOR AT pathway, which would be a way to increase the glucose uptake into the cell, and which is essential for cellular growth and, of course, for the dissemination of cancer cells. Another issue is, of course, the lipid uptake into the cell together with free fatty acids. They are the cursors for the growth of tumors and their metastasis and even their resistance. And we know that through different receptors, through different cellular pathways, the genetic mutations with the epigenetic alterations would lead to cancer. And there are targeted therapies together with chemo and radiotherapies that are targeted at different steps along the pathways, which are used for the treatment of endometrial cancer patients. And also there are steps along the lipid metabolism where the patients having lipid metabolic problems might benefit, because the metabolism might be another cause for endometrial cancer. So you would see that at some points there are additional treatments which might work together for the treatment of endometrial cancer. And having said that, I thank all of you for your attention.
Thank you, Professor Yoldemir. It was a tough lecture. It was a very good, very in-depth mixture of the pathways, of the genes, of the metabolic disorders and everything. So I felt that endometrial cancer is a kind of clear disease to me, but now I'm a little bit uncertain. Okay, we are going to discuss it, but we need to proceed. And our second distinguished faculty is Professor Ludwig Kiesel. Welcome, Professor Kiesel. Professor Kiesel is the CAMPS representative of the German Menopause Society in IMS and former chairman of the Department of Gynecology and Obstetrics at the University of Münster in Germany. He studied medicine in Heidelberg, Germany, and in London in the UK, followed by a research fellowship at the NIH in Bethesda, USA. And he's the past president of the German Society of the Gynecological Endocrinology and Fertility Disorders, past president of the German Menopause Society, as well as the German Endometriosis Research Foundation. And his research focus on hormonal cellular action and treatment in the menopause, breast cancer, and endometriosis. So this is really a privilege to have Professor Ludwig Kiesel here, and he's going to talk to us about the obesity and its relation to the endometrial cancer. Professor Kiesel, dear Ludwig, please.
Well, thanks very much for the kind invitation by ESG and the moderation. And I'm really glad that you have introduced me so elaborately. Now I'm trying to get hold of my lecture. I have the honor to speak about one very hot topic regarding endometrial cancer. And I'm doing this from my home university in Münster, which you can see the town on the left upper corner. And this is a medieval town. But luckily, you can see that the university hospital is quite modern, and we're fully acclimatized here in this warm temperature. So it's a very pleasant place to be and to discuss with you this topic in this webinar. Now, it has been seen for quite a while now that obesity is a risk factor for several types of cancers. And as you see from this chart, there is a dozen of obesity-related cancers, which has been found in different studies to be increased with obesity. And one of the very first ones which was found was actually endometrial cancer. And you see it on this table on the right, the different relative risks for different diseases. And these are related to the BMI the patients had. So one is related to a BMI of 25 to 30, and the other group was above 30. So you can even see here that it's not just increased endometrial risk, it even further increases with increased BMI. So that is something very important. So, and the other finding is that, as you see from here, it is even a higher risk than with female breast cancer. It is, as you know, obesity increases the risk of female breast cancer, but mainly in postmenopausal women, and endometrial cancer is way above this risk. So it is estimated that obesity will contribute to about 20% of cancer-related deaths. So that's a very important factor. Now, how is the incidence and mortality? Now, you can see from this chart that the incidence is, as well as mortality, is quite unevenly distributed in Europe. So when you can see from this colored chart, you can see the numbers, which is 15 to 20, etc., up to 40 rate per 100,000. So on the right, you can see the mortality, which is not exactly the same. So there are some countries which have a higher incidence and lower mortality than in others, and the other way around. So it's a quite uneven distribution of endometrial cancer in Europe, and it's quite challenging to understand all the details. Now, of course, we'll concentrate on obesity, and it is a global pandemic. We know this for a long time, and you can see some on the left side that the adults, the share of adults who are overweight or obese into 2022 is quite high. In some countries, it's much higher than others. You can see it from here that all the individuals who are above 25 BMI. So it is quite high in certain countries, much higher than others. And not only this is a problem, but the other problem is that is an increasing problem. So you can see on the right that from 1990 to 2022, there is a gradual constant increase in any place of the world related here. So you can see the gradual but very constant increase in all parts of the world. So what that says to us that we have a global burden of excess body weight. So if you see it from here, you can see the numbers. It's a 2.5 billion adults overweight and 890 million adults living with obesity. So that brings us to 43% of adults being overweight and 16% obese. So these are really quite significant numbers, and it seems that this is increasing year by year. So it's going upwards, and of course, we know that, which is not the topic today, but it is, of course, a risk factor for cardiovascular disease and premature death. Now, there is always discussing about obesity being measured by BMI. Now, this is a standard way of dealing with that matter in order to compare different areas of the world and different studies. Now, you can see the definition. It's related to the BMI, which is kilograms per meter square. And you can see the 5 groups: underweight, below 18.5. Then comes the normal range, which is regarded as normal. And then comes the grade 1, grade 2, grade 3 overweight. And there are also other names, like grade 2 being obesity, and then above 40, grade 3 being morbid obesity. So today we're generally talking about the overweight and obesity. So these 2 groups, generally comparing it to the normal range. It's very rare that we compare it to the underweight. Now, of course, people around the world are very different. So it has been discussed whether BMI is actually the right way of dealing with obesity measurement and definition. So it has been suggested that waist circumference and waist to hip ratio should be incorporated in order to better diagnose early metabolic dysfunction, especially because in Asian population where metabolic risk manifests at lower BMI. So that doesn't apply there. And waist circumference remains superior in diagnosing that in these populations. And on the other hand, we know that there are people with high BMI with a normal metabolic risk profile, and the other way around, being with a normal BMI, but having metabolic risk profile. So there may be some discrepancy between the risk and the BMI. And one solution is to add other things like waist circumference and waist to hip ratio, which is discussed in quite a few publications now. And but it's difficult to move away from that standard BMI yet. But I think you should be prepared in future to have that, especially because waist circumference is easy to measure. Even your patients can do it easily. So what is this BMI actually doing over the life course of patients? Now, this is a huge study which is actually looked at that matter, and that was looking at 2.6 million Catalan adults over the period of 9 years. So the idea was to figure out whether duration or age of onset of that increased BMI or the BMI at the actually index date, which is the time when endometrial cancer occurs. And all these factors are actually increased. So it is important to know the duration, but it is also the age of onset. So if you have if you have obesity very early, that is an important risk factor. And this is, of course, will lead to the consequence to have prevention methods very early, which often is disregarded in young women. So if you look on the right, you can actually see the 2 different BMI scores and its development of hazard ratio. So if you look, for example, at BMI above 25, which is green, and over the time, with the increased duration, this will go up, and it is not just linear, it is more than linear. The same with the duration of BMI above 30. So the longer duration and the greater degree of obesity during early adulthood, as well as younger age of onset, of a high BMI are associated with a higher risk of not just endometrial cancer, but many other cancer types as well. So this is something important, and it's not just linear, it is even higher. Now, how does this all work? How come obesity does this? Now, in your first lecture, it has been already alluded that this is a quite complex matter. So this is one of the complex slides to show that what happens when obesity is present. Now, obesity, it will affect, of course, many things, or will include many things. Adiposity, the amount of fat, it of course matters where it is, whether it's visceral or not, whereby visceral being more important. Now, because fat tissue is not inactive, so it will secrete a lot of things, and this is a very simplified slide showing just one, but there are other factors which will influence other organs. So in this cartoon, you can see the different organs which are altered in obesity, and also the step why is a kind of didactic way of telling us what will happen on a systemic level. There will be local and systemic hypoxia, certain parts, inflammation, insulin resistant, and hyperinsulinemia. And this has been discussed already in the previous talk. So the pathways which are involved here are listed here, and also the ones which are then affected. And what happens is that obesity will actually change angiogenesis. It will change fibrosis, which matters for cancer, and of course, cell proliferation. So this is what you can see here. And the numerous agents which are involved are listed here. Now, some of them you can actually measure. So you can measure on blood, and it's listed here on the left, what is changed in women and also in men. So as we heard before, insulin level is increased. IGF is a non-linear relationship with a peak level at certain BMI. And then there is a free IGF-1 you can measure, which is increased. Then comes the binding proteins, which are, depending on which one, is either decreased or increased. So that's different again. And very important in gynecological and endocrinology, SHBG, which is has decreased levels with obesity. So that's important to know. And you heard a lot about the testosterone and androgens in the previous talk, which are changed. And also estradiol is a total measurement, but also free estradiol and progesterone. So you can measure a certain endocrine or endocrine-related hormones in order to understand better, but also you can interpret the levels better than if you know if the patient is obese or not. Now, here is a very complex cartoon telling you all about obesity, which relates to changes which are important for endometrial cancer. So here you can see what happens if you've got an excessive adipose tissue, which is basically becomes dysfunctional, which means that a number of different cells are excreted, and these cells and their products will lead to changes in tissue. So there will be a tissue remodeling, as you can see here, and this will eventually lead to chronic inflammation. And we are getting to understand that chronic inflammation, even in a lower scale, will have a large effect in many organs. So other things, apart from this chronic inflammation, which is low grade, and there will be changes in tumor microenvironment. There is hypoxia, as I mentioned before, and of course, disrupted estrogen signaling, which eventually will change signal pathways, as mentioned here, as well as insulin production. Now, we know that wide adipose tissue will cause an imbalance in calorie intake and expenditure. Now, this is well known, and hormonal changes we've discussed already. Now, I think something is very important, epigenetic changes, which means you change the genes, or at least the activation of these genes, And this can happen even if you had earlier obesity, and then after losing weight, these epigenetic changes may remain. So that's unfortunate that in younger age, having obesity has an effect after later in life, even though you have already reduced your weight. So that again tells us that prevention has to go back very early. Now, interestingly, also your day-to-day life will be changed because circuit rhythm may be changed due to obesity and many other things like lipids, as we heard earlier. And in the past few years, we got more information about the microbiome, which will actually change the imbalance in metabolism. It will also increase chronic inflammation, cause actually DNA damage, and decrease short-chain fatty acids. So this is a rather new field, and it will affect many things in life of women. And this is a cartoon telling you a little bit about this. And I'm personally involved in some research, so I'm really thrilled to see how this will work out. So changes in gut microbiota are relevant because it can actually change the level of estrogens, which is called the estrobolome. So it means that if you have an enzyme which is in the gut and can actually increase estrogen levels, which is shown here. And there are also other effects by the gut microbiota regarding insulin resistance. Now, obesity itself will change the steroid levels, as we heard earlier, and this will affect a number of changes. So microbiome itself will add on to obesity, and this will result in some of the changes which may lead to endometrial hyperplasia. Now, how does this actually work out in the different steps in pathology? Now, obesity will have some changes, as we just mentioned, and of course, estrogen level changes, SHBG level will drop, so the free estrogen will be increased, which is important. Insulin, which is also a kind of a growth factor, is increased, and inflammation is increased, which produces factors which altogether will stimulate endometrial proliferation. So that will increase hyperplasia risk and will have increased intraepithelial neoplasia, EIN here, and thereafter it may move on to the carcinoma changes. So obesity per se doesn't really induce cancer directly, but it will promote proliferative environment in endometrium. So that's the current knowledge, although there are some indications that indirectly they may change the risk of endometrial cancer apart from just proliferation. So how does this affect diagnosis and treatment of endometrial cancer if a patient has obesity? And the main factors are listed here. So diagnosis may be delayed due to the size of the patients, and some other things can be also altered, like imaging, biopsy, and of course comorbidity in these patients are significantly different. But also the therapy. So maybe depending on the size of the patients and the body surface, chemotherapy might be underdosed even, and radiotherapy planning can be more complicated. So that actually influences also the treatment of endometrial cancer. And in general, obesity worsens the treatment of outcomes, and that's due to greater surgical complication, thrombotic events in obese patients, longer hospitalization, and resulting in poorer survival and higher cancer-specific mortality, which is about 2.5-fold. The other thing is that performing surgery, so those of you who perform surgery know that problem. It's not easy to do surgery on obese patients sometimes, and it can be so difficult that even laparoscopy is a challenge because of the Trendelenburg position of these obese patients. but there are more options now with the robotics, I guess, and we'll be able to handle that better. So I think that's something which is evolving. But in general, obesity is associated with higher rate of perioperative complications and morbidity, and that's of course something which is relevant. Now, what can we do about these risks? There are studies investigating weight loss interventions, so reducing obesity, and also bariatric surgery. And this has been shown to have a protective effect on endometrial cancer risk. So this is a summary of the present studies which have been published looking at these either weight loss interventions or bariatric surgery. And the summary tells us that it is actually reduced to the half of the risk in those 12 studies, which has been demonstrated. And bariatric surgery actually demonstrated the greater effectiveness. So this is quite remarkable effect. And the effects are generally seen on the type 1 endometrial cancer, which is predominantly associated with obesity, as is since it's estrogen dependent. So that's quite a remarkable effect in those women to reduce their risk. Now, another way would be to use metformin to interfere with all the metabolic changes we have just discussed before. So metformin, which you know for many reasons and for many indications, metformin is thought to be acting either directly, which is here in the cartoon on the left side, so the direct tumor effect, and there will be change in the metabolic reprogramming, inhibition, signaling, and also in endoplasmatic reticulum stress. So there are 3 intracellular mode of actions which are directly affected in the endometrial cancer cells by metformin, but there are also indirect changes which I pointed out before regarding insulin and insulin-like growth factors. So these are changing these will also change also the risk factor. So metformin is presently investigated in its anti-tumor effects, but it is actually not well studied so far to be able to recommend it as a risk-reducing administration. It looks like is it actually having some effect on patients who have endometrial cancer. So it will probably take some time to have some RCTs to study the preventive effects. Now, of course, another agent which is obviously used in obesity are the glucagon-like peptide 1 receptor agonists. And these have been studies, and there are already now a systematic review and meta-analysis to look at how these glucagon-like peptide receptor agonists will affect obesity-related cancers, just like endometrial cancer. And as you see here, the summary is shown here on the right bottom, that after 5 years taking the drug, it is not significantly different, the risk. But if you take it after 10 years, this risk of endometrial cancer reduction will show. So it is significantly reduced. And the numbers of studies with the patients, number of patients, is quite high, as you can see. From here's listed the numbers, and here are listed the studies. So it is quite significant effect, but it takes time. So it will be some years until its effect is clear. So weight loss as a way of treatment or actually prevention about 5% intentional weight loss is already associated with significantly lower risk of endometrial cancer in obese postmenopausal women. So that has been shown in WHI observational data, telling us that if you tell patients that already a small reduction of weight will already reduce their risk of endometrial cancer. So this risk reduction signal has been shown in many other studies. So all in all, it shows that the relative risk is going down to 0.61 to 0.96. So that's quite good. And the way this weight loss will help is shown here, which we have discussed, that mainly the adipose tissue aromatase activity is reduced once there is less fat amount, and thereby the estrogen exposure in patients will be reduced. And on the other hand, SHBG will go up again once weight loss is done, and the bioavailable estrogen is going down. And at the same time, insulin resistance gets better, and chronic inflammation is reduced, and the adipokine recirculation is also normalized. So the clinical takeaway is that weight control is a key primary prevention strategy, which is quite obvious. It has to be linked with healthy diet and physical activity to support this risk reduction. And the evidence is strongest for prevention before cancer develops. And of course, it has shown before at earlier age. So my final slide gives us the summary and also the take-home messages. So the established evidence up to now is that obesity is a major modifiable risk factor. So endometrial cancer risk increases with higher BMI. And the key biological mechanisms are well established. We have discussed them in full detail about aromatase changes, estrogen, SHBG, and the insulin pathways, as well as chronic inflammation, which is they are all very important. So the best prevention evidence is weight loss before diagnosis. So of course, preventing the disease, preventing endometrial cancer. So it should be an intentional weight loss to lower the risk. And in some patients, bariatric surgery is done, which actually is very effective and showed in studies the strongly preventive signal in patients, at least in selected patients. Unfortunately, obesity has its perioperative implications, complexity of surgery, and wound-related morbidity, and if possible, of course, minimally invasive surgery should be preferred because laparotomy has its own risk in addition. So modern care is actually guided nowadays by a molecular classification of the disease. So it's very important to understand this, and it also by the current systemic therapy standards. So what you have to watch out for is on the right side. These are the emerging concepts. So the metformin repurposing, this drug has been around for a while, and it has a strong biological rationale, as I pointed out, as with its direct and indirect effects, and also the very increasing use of GLP-1 receptor agonists. And there are quite promising signals, and this, I think, is important. And a very new field is the microbiome and the gut-uterine axis, showing a different actions, direct or indirect, and regarding estrogen, but also others. So there's a whole new field. And weight loss after diagnosis of the disease is not certain whether this actually helps. So it is essential to do it beforehand. And of course, future directions are to combine all this knowledge which we presented today in order to able to allow the use of biomarkers and in different subtypes of disease to get better diagnostic therapeutic agents. So the bottom line is to address obesity early for primary prevention and evaluating emerging metabolic interventions in prospective studies. And with this, I thank you for your attention. The final slide is Münster today.
Yeah, thank you, Professor Kiesel. It was a really very important clinically focused lecture, and I think that the gynecologist has to put more focus on the question of the obesity and take more time with discussing the importance of the obesity with our patients in the postmenopausal and the reproductive ages as well. So now it's time to discussion. Let's see whether we have questions and answers. First, I ask my colleagues, the lecturers, the speakers, whether do they have questions to each other? Well, if not, let's see whether we have questions. Yes, we have a question. The first question is from Elena Rota. She's asking that in some countries, the question goes to Professor Yoldemir, that in some countries there is a new test of saliva testing microRNAs to diagnose diagnostics of endometrial cancer. What do you think about the usefulness or the importance of this?
I think it's a very thank you for the question. I think it's a very brave attitude to just relate the endometrial cancer only to microRNAs. It's of course, one of the causes that would be related to epigenetic modifications, but we know that it's not the only way that would be the cause of endometrial cancer. It might seem promising, but as I had shown in two of my slides, like more than 100 microRNAs are taking in action through the, leading to endometrial cancer. And I'm not sure which pattern or which composition of the microRNA in that kit will determine. Remember, we are wishing to detect the endometrial cancer at an early stage so that we can, do the best with treatment options. So in that case, I'm not quite sure, but it might be promising.
Thank you. Yes, I also feel that as you told several factors about in the risk factors for endometrial cancer, metabolic and genetic and inflammation as well. So microRNAs can be only one piece of the puzzle. It can give some additional information about the basic risk of endometrial cancer, but I also feel that at least at present that the clinical features like the obesity and the metabolic disorders, the hormone levels are much stronger determinants of the risk of the endometrial and other endocrine related or gynecologic cancers.
Maybe I just can add to this.
Sorry?
Maybe I can add also
Sure.
Well, we have a great interest in microRNAs, has been for quite a while now. And one area where the saliva test is now performed, there are many studies already performed, is in endometriosis, which is not the same, of course, but it is just showing you that in the saliva, which is readily available and it's easy to perform, but not cheap to do these tests. So I think there was a great hope because these kind of so-called liquid biopsies, where you don't take a biopsy, is I think one of the major future things. It doesn't mean that we are there yet. So we can't say exactly, because if you look at the literature, there are some inconsistency if different groups measuring the same sort of panels, and they don't come to the same results. So it's a challenge. But as you know from endometriosis, it's already a drug, which is, well, not a drug, it's a diagnostic measurement. It's already available. So it's I'm not saying this is the end of the story, but it's already there. And the same thing is happening now for other diseases. So we are on the way there, but I'm sure we need some more time to get the final answer. But since microRNAs are stable and it's unrelated to the cycle of the women, so you can really use it. It's not like RNA, which is destructed early on. So I think this would be something which would be available in many countries where you can't perform surgery and things like that easily. So I personally feel very strong about using that knowledge, but we are, I think, not there yet.
Not there yet. Okay, thank you for this very good, valuable comment. And so the next question is also goes to Professor Tevfik, that he mentioned the association of, the question comes from Hemanta Perara, and can Professor Tevfik mention the association of parity? It was thought to be more common in nullipara, but I thought your slide showed a different one. So
Thank you for
you mentioned the parity, yeah.
Yeah, it was one of the subgroup analysis, and remember they discussed in one table the effect of testosterone, and in the second the effect of sex hormone binding globulin. So for the testosterone table, there was no difference in terms of the parity, but with the sex hormone binding globulin level, it was only in those women who had more than 2, the significance was not there. So maybe, having more children might not be, as we generally know, might not be a risk for endometrial cancer there. But in only when we consider sex hormone binding globulin. So this is not a table that shows the cutoff values. It's just to show the relationship between the cancer risk and the levels of either serum testosterone or sex hormone binding globulin. So personally, I don't know if there is a well, it's not in my talk, so I didn't mention any difference in terms of the parity. So these were the subgroups that they had to kind of adjust the model with, and it's just the result.
And what is the relation between the parity and the risk of the metabolic disorders or the any kind of further risks of estrogen-related cancers in a quite uniform community? So I mean, the question was from the audience that the parity itself, but maybe the parity relates to the metabolic consequences, obesity, and that will determine the risk, maybe.
I think, well, if it is not related with this study, we know that the endometrial, well, the parity should be discussed whether it's null or 1 or more in terms of endometrial cancer, because there are other conditions like PCOS. We haven't mentioned that. the presence of PCOS is another condition where the endometrial cancer risk is increased due to the factors that Ludwig and I mentioned, and that's something else. But just by parity, I think our Pereira, Hemanta Pereira, mentioned about the slide that I used during my presentation, and there it was just a statistical finding, nothing more, nothing less.
Okay, thank you. Any comments from Ludwig?
No, I think it is possible, of course, that there is a higher rate of PCOS or PMS in women with null parity or low parity. So I think that there may be some indirect effect, which I think has not been worked out very well. But if epidemiology is not for it, then I can't tell better data than that.
Okay, thank you. So, and we have also a the question from Hemanta Pereira. What would be the effect of the testosterone replacement?
Well, let me mention about that. In that slide, the testosterone level was shown to increase endometrial cancer risk both in the premenopausal and in the postmenopausal group, as you would remember. So the conditions are different there. The postmenopausal women have less testosterone. So during the talk, I had to answer one question just by writing. The only way that testosterone is recommended to a postmenopausal woman would be in terms of hypoactive sexual disorder. So she would first need the estrogen replacement, and if she's not happy with that, transdermal testosterone might be added on that treatment. And here the objective is to reach to premenopausal serum levels. And if they do not reach to that levels in a couple of months, and the patient has not recovered from the from her complaints, then there is no need for further testosterone usage. And as far as I could see, there is no cutoff value for the testosterone. It's just being shown that women who had endometrial cancer has higher testosterone levels than those considered as the control group. And since I looked at the reviews, which included different couple of papers, there was no cutoff values there. So it's for me to answer this testosterone replacement, whether it would affect the progression of endometrial cancer, would be very tough. So I really don't know the answer.
And I do think that those women, postmenopausal women who are at risk, obese and at risk of endometrial cancer, they are not the candidates, the perfect candidates for the testosterone replacement, usually clinically. But that's okay. So do we have any more questions? Also from Hemanta Pereira, she's asking that in the backdrop of obesity and cancer risk, do you think levonorgestrel IUI device for contraception may be prophylactic?
Ludwig, this is your area.
Well, in general, it is. So I personally think, coming back even to the testosterone replacement, I mean, that even though there are some data direct testosterone action, it goes by aromatizing some, at least partially. So if you add progesterone, this is the old story, it may affect. I'm not sure whether there is really good data for that. But now, in general, I'm probably in favor of doing this. So I see no real something against it, except it's off-label. So at least in many countries, this levonorgestrel IUD is not is off-label. So you can do it, and it's often done because it's very convenient to administer the progesterone, and I think it will have effect. So I personally has very little side effects if you can place it well, which is sometimes also a challenge depending on the anatomy. But I wouldn't be against it. But since it's not it's off-label, you can't advise it to use it in general as a prophylactic in general. So you can discuss it, of course, and one could do it.
However, in the clinical practice, also in my country, levonorgestrel IUD or intrauterine systems are not infrequently used for endometrial protection with estrogen replacement in postmenopausal women. On the other side, that there are some research meta-analysis data showing that intrauterine levonorgestrel devices may increase the risk of the breast cancer on the long term, longer use in postmenopausal women. What is your opinion about that? If already we are talking about the obesity and the IUD.
I think it's not resolved yet. I mean, there is some publications on that risk in, I think these are mainly registry studies. But anyhow, it is a low concentration, but it's a continuous administration, and it can act systemically. There is no, and this question has been ongoing for quite a while. So this is now not regarding endometrial cancers. Now we're talking about, of course, breast cancer risk. So you have to weigh, you have to balance things, and it's often used. So it's a good question, but I can't really provide new data on with regard to the risk of breast cancer, which is published. So it is reasonable point to discuss. But I think you have to discuss anyway, weighing these things, because this IUD is off-label for that purpose. So anyhow, you would have to go into details more than with in premenopausal women for contraception. So this is now a different amount of communication on that respect.
And why not go with diet and exercise? And you know, I know it's hard. It's hard for the individual, but it's
can be very well. That's right, but that's a difficult problem.
We have a question yet. Can we protect the endometrium by Leuprolide and give add-back estrogens or testosterone to postmenopausal women?
I think it's possible, but it's not feasible. It's possible, but it's not feasible. Why go all the, hustle, first medical menopause, then give the add back? I think this shouldn't be an option.
But I'm not sure I got the question right, because in postmenopause women, you would not need leuprolide, which you administer only premenopausal.
I think this is for women who has obesity, and this is for the prevention of endometrial cancer. I think the question, yeah.
Oh, because it says postmenopause women, I may misinterpret it at this point.
Because she's postmenopausal now.
And at risk of
due to leuprolide.
Yeah, probably, yeah.
Okay.
I mean, it's like showing the right ear with the left arm. I mean, I don't know. And it's expensive. The leuprolide is expensive, and please, it's not the topic today, but estrogen plus testosterone is very, I mean, it should be recommended to a certain type of woman who have hypoactive sexual disorder. Other than that, that person might not need the testosterone. So just be
the indication
certain about that.
To those women with HSSD. Okay. So, well, I think now we are sitting here for almost 1.5 hours. It was very exciting. We learned a lot. If there are no, one more question we have, the tamoxifen and endometrial cancer. We need to make annual vaginal echography. Do you perform annual?
I think
in Germany, we have done in our guideline of breast cancer and endometrial cancers that we don't need to do it. We are even not doing vaginal ultrasound for endometrium in normal women. I mean, I'm not talking of high risk, but tamoxifen without bleeding is not investigated. So there are many changes on vaginal echography, which is misleading, and so it has been stopped doing that. And so at least in my country, it's a clear no, unless there is bleeding, and unless, of course, it's with a very special case with familial increased risk of endometrial cancer with genetic disorder, etc. So there may be other things, but this is not due to tamoxifen. Although the tamoxifen increases risk of endometrial, so that's probably the idea, but it's not recommended to do it on a regular basis. It's with bleeding, yes, but not without bleeding. But this may be different in different countries.
Yeah, it is different because I do agree that the ultrasound features of the endometrium can be very misleading, with endometrium with cystic structures under the thin endometrium. But at least in Hungary, on the indication of the oncologist, once a year sonographic screening should be done. But certainly the bleeding counts more than the sonography for us also. But I think that let's finish with the last question, because maybe it's interesting that Hemanta Perara asks again that she's living in Sri Lanka, and where PCOS has become epidemic. And she's wondering whether there are many epigenetic influences in the intrauterine life, such as androgenic food. Please comment. Tevfik, androgenic food.
What do we mean by androgenic food? Meaning meat or? Well, I think it's all related with the insulin resistance, as Ludwig mentioned, and I tried to, show the pathways. It's related with the insulin resistance in some group of the PCOS patients. And of course, the food is quite important there. The glycogenic index will determine, and some would be obese, some would be lean, but having the insulin resistance. I think it's not the PCOS by itself, but the metabolic features that are related with the endometrial cancer.
PCOS risk is increasing in the developed world,
Yeah.
as well as obesity
And
and GDM risk.
And we know that PCOS born children are, children who are born preterm with IUGR conditions, they try to catch up during the childhood, and they are prone to have type 2 diabetes and insulin resistance further in their life. So this might be related with the prenatal period, but it's all related with the metabolic problems of the PCOS, I guess. But at least this is my assumption and comment.
Yeah.
Ludwig?
Okay, I think we have to close the session.
Okay.
We have to close the session. So, thank you for the lectures, dear gentlemen, and thank you for the audience coming. And now I'm going to close this session, and there is some last advertisements. The next session is going to be about the POI. And everybody is welcome and invited. And we have another slide, the last slide, which is about the biannual next Congress of the European Society of Gynecology, which is going to be held in Porto next March. Indicated your calendar. And thank you again for the attendance. See you later.
Okay, thanks very much.
Thank you.
Thank you.
Bye.
Have a nice day.
Have a nice day.
Bye-bye.